Hello, my name is Sven de Keyser. I am a neuroradiologist at Ghent University Hospital in Belgium, and welcome to this presentation on how to read a brain MRI. This is going to be a very basic presentation, not advanced at all. And what I want to do with this presentation is, if you're a radiology resident or a medical student, we all have that moment where we sit in front of a computer and we've read a lot about MRI of the brain, we've studied anatomy, we know what a glioblastoma looks like based on articles we've read, stuff we've read on the internet. But then comes the time and we sit in front of a computer, have to report our first MRI, and we just don't know how to get started. The patient doesn't have a tumor, so that we know what a glioblastoma looks like doesn't help us at all at that moment. We see a lot of stuff and we just don't know what to make of it. In this presentation, I'm going to teach you my personal approach to an MRI of the brain. What sequences do I look at? In what order do I look at them? And what do I look for in a specific sequence? So I'm not going to show you a lot of pathology. I'm going to show you normal images that nevertheless contain stuff that's not perfectly normal, but okay for the age of the patient or for that specific situation. Let's get started. So first of all, we have to know what sequences we look at. There's another presentation on this channel on the basics of an MRI of the brain. Look at that if you don't know yet what a specific sequence looks like and how to recognize them. If you do, keep watching. So what are the standard sequences and what does a standard MRI of the brain look like at my hospital? Well, we do a FLAIR. We do T2-weighted sequences, sagittal T1-weighted images. We perform axial diffusion-weighted images, and of course, we automatically get the ADC map when we do, and we also do T2 star images or susceptibility-weighted images as part of our standard screening MRI brain protocol. When looking at a standard MRI of the brain, I always start with the FLAIR sequence. And why is that? Well, most pathology is hyperintense on T2-weighted images and FLAIR images because it contains a lot of water. It's not always true, but it's true for most of the neuroradiological pathology. And a FLAIR sequence is basically a T2 sequence, but it just shows pathology a lot better by nulling the signal in the ventricular system and the subarachnoid spaces. So by removing the T2 hyperintense signal of cerebrospinal fluid, we actually are able to detect pathology in the brain a lot better. So I go through my FLAIR images to do a quick pathology check. I want to know if something is wrong or not. And generally, by going through the FLAIR images, I immediately know or quickly know if the patient has significant pathology or not. If the patient hasn't, I continue. And what do I do when looking at FLAIR images? The first thing I do is I check the degree of cerebral atrophy. A lot of patients are older. We see a lot of atrophy in daily radiological practice, and I give an estimate on the presence and the degree of cerebral atrophy. Then I look at the white matter because we very often see white matter lesions. In a lot of cases, they have no clinical significance for the reason the scan is requested, but we see them nevertheless, so we have to report them and make something out of them. So that's what I do next. And I also check the size of the ventricles. I do that when looking at my FLAIR sequence, but of course we can evaluate ventricular size on basically any sequence. So the pathology check, I do it on the FLAIR, not on T2. Why is that? Well, let's look at these T2-weighted images. The patient has an abnormality here, and maybe you've already seen it, maybe you haven't, but if you look at the FLAIR images, it's immediately clear where the pathology is located, over here in the left temporo-occipital transition area. There is a small area of T2 hyperintense edema, and this was caused by, and that we can't see on these images, but that was the reason, it was caused by a small cortical vein thrombosis. So FLAIR is, as said, a lot more sensitive, or it allows you to more quickly detect pathology. It more quickly jumps to the eye. Okay, moving on. If the patient has nothing that looks like significant pathology, I evaluate cerebral atrophy. There's a wide degree of cerebral atrophy in terms of severity. A patient can have no cerebral atrophy whatsoever, like in this patient, for instance, or it can look very severe. Of course, there's a huge difference between, let's say, a 20-year-old patient. It's normal to have no atrophy whatsoever. If a patient is like 85, we can expect to see a little bit of atrophy. Well, a little bit. We can expect to see some atrophy at least. And the real question is, when should you consider it abnormal or not? Why do I evaluate atrophy on FLAIR images? Because if you look at the two-weighted images, you will tend to overestimate the degree of cerebral atrophy. Compare the degree of cerebral atrophy between the FLAIR images in this patient and the two-weighted images. On the two-weighted images, you'd say that a patient has at least a moderate degree of cerebral atrophy. However, on the FLAIR images, this looks a lot less pronounced. So always evaluate cerebral atrophy on your FLAIR images, not on the two-weighted images, because otherwise you might overestimate it. You can also use T1-weighted images, but at our center, we do sagittal T1-weighted sequences for a standard MRI of the brain, and I like to do that on axial images, so I use the FLAIR images. Now the question is the degree of cerebral atrophy. Patient can have no cerebral atrophy or can have cerebral atrophy, but then the question is it a lot or not? And how can we quantify that? Well, we can't really measure it. You have software algorithms that can give you an exact quantitative degree of how much cerebral atrophy a patient has, but in most centers that's not available, and we have to use our eyes. So it will be subjective, but we have something that can help us, and that is a scale, the global cerebral atrophy scale. Let's compare a couple of patients. I'm showing you the images of 4 different patients, and we see that the degree of cerebral atrophy increases in each consecutive patient. This patient has no atrophy whatsoever, and what does that look like? Oh, let's remove that. Well, we see no widening of the sulci whatsoever, and in these patients we see gradual increase of the sulcal width. So we can use that to the degree of sulcal widening to give a semi-quantitative estimation of the degree of cerebral atrophy. What I find extremely important is I see a lot of my residents do that as soon as a patient has some kind of atrophy, whether it's a little bit or a lot, they use phrases like patient has age-related cerebral atrophy. And then my question always is, what's normal for the age of the patient? And generally, they are not able to answer that question. Something I always tell my residents is, if you are not able to answer a question, if somebody were to ask you, what does that mean in your report, age-related cerebral atrophy, and you can't answer that, you can't give an answer, you should write that, because basically you don't know what you're talking about. So avoid this unless you have that much experience that you're quickly able to estimate if it is normal or not for the age of the patient, and even then you might be wrong. Also, refrain from using the term cortico-subcortical atrophy. I see that a lot in reports, but have you measured the size of the cortex and what is normal for the age of the patient, and why subcortical atrophy? Does that mean that the deep white matter does not regress when we age? It's a meaningless term. So refrain from using those, although it is tempting to do so. Instead, use the global cerebral atrophy scale. And how do we use that one? Look at the width of the cerebral sulci. They can be completely closed. That's normal. And in that case, it's a grade 0. They can be slightly widened. We can have some mild sulcal dilatation. In that case, it's a GCA grade 1. And I call that a mild cerebral atrophy to make it more clear for my referring physician what it means, because not everyone is a neurologist with experience and or with an expertise in dementia. Then we have moderate sulcal dilatation with some volume loss of the gyri. That's a GCA2, and I call that moderate cerebral atrophy. And lastly, we have severe or knife blade atrophy, in which the gyri look knife sharp. I call that severe cerebral atrophy, and that corresponds to global cerebral atrophy grade 3. And here is the knife blade gyrus and the right parietal lobe. Now the next question is, if you do that, what is normal? What is abnormal for the age of the patient? Well, very simply put, a GCA2 is okay if your patient is 80 years old. As soon as a patient is over 75, we can say, well, GCA2 is okay. GCA3 is always abnormal. So this is just something to help you on your way. When should you report an abnormal atrophy? Well, this is an example from daily radiological practice. So, for instance, the patient comes because he has a chronic headache. And then we look at the FLAIR images and we give an estimate on the degree of cerebral atrophy. And I'd say this is a global cerebral atrophy grade 2, so moderate cerebral atrophy. I write it down in my impression, and then when it comes to my conclusion, I have to make an estimate on, am I going to report this? Is this important enough to report it, to point the attention of my clinician to it or not? Then I look at the age of the patient. The patient is 47. That's very young to have moderate cerebral atrophy. Furthermore, the patient had very severe cerebellar atrophy, and this was a patient with chronic liver disease due to chronic alcohol abuse. And chronic alcohol abuse, unfortunately, is a frequent cause, in my experience, of age abnormal cerebral atrophy on imaging studies. Of course, I do not make the suggestion that the patient might be an alcoholic, because this might not be true. I don't know that for certain. I know in this case because it is documented, but in other cases I might not know it, and I don't want to put a label on a patient. So if I don't have any information, I would just write my report and at the end say that I find the degree of cerebral atrophy very pronounced for the age of the patient. That's still very descriptive, but it already gives an impression that I think this is abnormal, and if the patient has cognitive complaints, this might lead to a further workup of the patient. Then I look at the white matter. If you look at these T2-weighted images, they look completely normal, but on FLAIR images, we suddenly see a very small punctate white matter lesion in the left frontal lobe. What should we do with it? Well, that will come next. The main thing here is look at FLAIR for the detection of white matter lesions. It's a lot easier to detect them on FLAIR compared to T2-weighted images. And that's not only true for these very small lesions. If we compare these two images, we see that these patchy white matter lesions are more easily detectable on the FLAIR images as well. And suddenly we see a lot of other lesions that we might also see on T2, but it's so much easier to spot them on the FLAIR images. So use the FLAIR to look for your white matter lesions. What should you know about white matter lesions? Well, first of all, I'm doing it wrong. I try to refer to them as white matter hyperintensities because they are not always pathological or should not always be considered pathological. So by using the term white matter hyperintensities, I kind of try not to make every white matter hyperintensity I see a pathological entity. They are extremely frequent. We can see at least one white matter hyperintensity in 25 to 37% of the general population under 45, and in the population over 45, 90 to 95% has at least one white matter lesion. So they are white matter hyperintensity. So they are extremely prevalent even in young people. And this is an example of two young people, a 35-year-old female patient and a 39-year-old male patient, and they both have one subcortical white matter lesion in the left frontal lobe. Here it's more basally in the left frontal lobe, anteriorly of the insular cortex, and here it is high up and the superior frontal gyrus. What should we do if we see one or just a few of these punctate white matter hyperintensities in young patients? Well, this is personally, I don't do anything with those. I see them a lot, and if they are located at very typical locations like the subcortical white matter of the frontal or parietal lobe, and especially in the superior frontal gyrus or over here anteriorly of the insular cortex, I see these so often that I really have my doubts that they have a pathological correlate or a certain pathological significance. There are a few pathological studies out there that have described that these very punctate lesions are often the result of some gliosis around perivascular spaces and do not reflect microvascular disease. So what I never do is call these old vasculoischemic lesions. If I'm dealing with just a few punctate lesions, especially subcortically and the frontal or parietal lobe, I never call them old vasculoischemic lesions, and I certainly never write something like multiple sclerosis cannot be ruled out. I don't do that. I try not to overcall them. I call them, as already said, T2 hyperintensities instead of lesions. And if I really want to do something with them, I just call them unspecific. So I'm not giving a very specific diagnosis or entity. There is sometimes worry that as soon as we're dealing with white matter hyperintensities in young patients, could it be multiple sclerosis? Well, there is something called a radiologically isolated syndrome, which means that the patient has the MRI appearance of multiple sclerosis without having clinical symptoms yet. So it is known. So when should you call multiple sclerosis or when should you be worried about it? Well, first of all, it is more likely that you're dealing with unspecific white matter hyperintensities because these are so prevalent in the population than that you're dealing with multiple sclerosis. That's important to keep in mind. And there are specific criteria for multiple sclerosis, and you have to use those. So only call a finding of white matter hyperintensities suspicious for multiple sclerosis if these fit with the known criteria. And I'm very shortly going to repeat what those are. So we have here 3 patients. This patient had multiple sclerosis. And why did we call these lesions fitting a diagnosis of multiple sclerosis and these unspecific? Because if we take a careful look at the white matter lesions in this patient, and this time I can call them lesions, we see that they are located in certain locations that are very specific for multiple sclerosis. The patient has at least one periventricular lesion with an orientation lateral on the lateral, perpendicular on the lateral ventricle, a so-called Dawson's finger configuration. This is quite specific for multiple sclerosis. The patient has a juxtacortical lesion, a white matter lesion that is located immediately underneath the cerebral cortex. This is very specific. The patient also has an infratentorial lesion in the brainstem, and it is located quite eccentric in the brainstem. And lastly, the patient has several small lesions in the spinal cord. So there is a criterion. So you have 2 criteria, dissemination in space and dissemination in time. And this patient fits the criterion dissemination in space. To fit that criterion, you have to have at least one T2 hyperintense lesion in at least 2 out of 4 of these typical locations: periventricular, juxtacortical, infratentorial, and spinal cord. And this is the only situation in which I will make a statement like, this could be multiple sclerosis, the criterion dissemination in space is fulfilled in this patient. Only then will I do that. I'm not talking about dissemination in time. There are videos on this channel on multiple sclerosis. That's not the topic of this presentation. Then what should we do with white matter lesions in somewhat older patients? These are extremely prevalent, especially in the geriatric population. Well, a bit like we did with cerebral atrophy, we should find a way to give an estimate on the severity of the white matter, well, I'm now going to call it disease, the white matter disease. If we just have a few punctate white matter lesions, we use the Fazekas scale. We call that a Fazekas 1, so a few punctate white matter lesions. And very often these are not microvascular, we know from pathological studies. If the lesions are starting to become confluent, we call it Fazekas grade 2. And if we have confluent white matter changes, we call it Fazekas grade 3. And we know that these are very, very often microvascular in nature and a sign of chronic cerebrovascular disease. So when reporting my white matter lesions, I use the Fazekas scale to give an impression on the severity. If the patient has a Fazekas grade 1, I never say that these could be microvascular. I just say I see a few punctate white matter lesions over there and over there and over there. Fazekas grade 1, period. And if I add something, I call them unspecific still. If the patient has partially confluent or confluent white matter changes and as an older patient, I will say that these are most likely the result of moderate for a Fazekas 2 or severe for a Fazekas 3 microvascular white matter disease. And then, lastly, the ventricular size. We see that there is quite a lot of variability in the size of the ventricles in the population, and the ventricles tend to become wider as patients grow older. But that makes sense because due to cerebral atrophy and white matter loss, there's a lot more space, and ventricles can undergo passive dilatation. The most important thing is do not call, if you see some widening of the ventricles, don't call this hydrocephalus, because hydrocephalus means that the absolute amount of cerebrospinal fluid in the brain, especially in the ventricular system, is increased, causing increased intracranial pressure. And that's definitely not the case in this patient. When a patient has widened ventricles, you can describe that as a ventriculomegaly, and there are two important causes. Either you have a passive dilatation of the ventricular system because the patient has a decreased cerebral volume due to atrophy, or the patient truly has a hydrocephalus. There's an absolute increase in the amount of cerebrospinal fluid and an increased intracranial pressure. And the difference is not so difficult. If you see that the degree of ventricular widening accompanies a widening of the subarachnoid spaces, this is due to a decreased cerebral volume. If you see the reverse, you see narrowing of the sulci and the subarachnoid spaces and severe widening of the ventricular system, that will be due to hydrocephalus. This is a patient with hydrocephalus. It was a child, and I realize that we are now looking at the two-weighted images, but that doesn't really matter. We see that the sulci are very narrow along the cerebral convexities. We see that the patient has very widened ventricles. We also see severe widening of the temporal horns, and temporal horn dilatation is often very pronounced in hydrocephalus, and hydrocephalus often starts in the temporal horns. Furthermore, we can often see well, in this case, the callosal angle is normal, and a normal pressure hydrocephalus, it will be increased, but that's not the topic of this presentation here. The main thing is, if you see widened ventricles, just look at the width of the subarachnoid spaces. They should follow each other. And how should you describe that? Well, it doesn't really matter. Sometimes you can say there's a mild ventriculomegaly due to mild cerebral atrophy. There is some ex vacuo, to use some Latin phrases, ventricular dilatation, or there is some passive ventricular dilatation. I generally just write it down along with my cerebral atrophy. I write there is some mild cerebral atrophy with a congruent ventricular widening, something like that. When I'm done with the FLAIR images, I move to the T2 weighted images, and I use those at certain structures of which I know that subtle pathology is more easily detected on T2 than on FLAIR images. I especially look at the basal ganglia and the thalamus, the brainstem and the cerebellum. I look at, here it is, the cerebellopontine angle and Meckel's cave, and when I've looked at these structures, I also look at the vessels in the brain, the arteries and the dural sinuses. And these should be black on T2 weighted images due to flow voids. And lastly, I look at everything that's outside the skull. Well, not completely outside the skull, but outside the brain, let's phrase it like that, the paranasal sinuses, the mastoid air cells, the orbits, and the soft tissues of the neck for possibly relevant incidental findings. So I start with the basal ganglia and the thalamus. On FLAIR images, we see nothing out of the ordinary, but on the T2 weighted images, we see a very small hyperintensity there, and this was an old lacunar infarction. These are often better seen on T2 weighted images than on FLAIR images. The reason is a bit unclear, but I believe this might have to do with the fact that the content of these old lacunar infarctions is not cerebrospinal fluid, is probably protein-rich fluid, and this causes the signal not to become completely black on FLAIR images. As a consequence, the lesion is better seen on T2 because it is iso-intense or almost iso-intense to the brain on FLAIR images. This is another patient. We see that the patient has some caps along the frontal horns and some white matter changes. And on T2 weighted images, we see a lot of very small T2 hyperintense punctate foci in the basal ganglia and also in the thalamus on both sides. What we see in the basal ganglia is a so-called état criblé, French term, a cribbled state, due to the presence of a lot of very small widened perivascular spaces. The cause is a bit unclear, but might have to do with chronic hypertension. And we also see these hyperintensities in the thalamus on both sides. Some of them will probably be perivascular spaces that are widened, but this one has some gliosis around it, so it looks like an old lacunar infarction. Let's move on to the cerebellum. On FLAIR images, I see nothing out of the ordinary, but on T2 weighted images, I suddenly see a couple of linear T2 hyperintense lesions. These are very old and arterial cerebellar infarctions. These are located in the cortex of the cerebellar hemispheres. They are not that infrequent. They are described in up to 11% of the older population. And because they are very small, they are often clinically silent. So we often see these very old chronic infarctions as an incidental finding on an MRI of the brain, and the patient never had an acute clinical episode, in most cases, due to these infarctions. But nevertheless, they are not completely irrelevant because they are a marker of cerebrovascular disease. These images here illustrate why FLAIR isn't enough, not just for the basal ganglia and thalamus, but also for brainstem and cerebellum. Another case of a silent old cerebellar infarction in the left cerebellar hemisphere. Look at the FLAIR images, strongly magnified over the brainstem. This is the pons, this is mesencephalon, I believe. And we see on T2 weighted images a lot of old lacunar infarctions, and we also see what it looks like the superior pons. I said the mesencephalon, but looks like the superior pons over here. This is also an old lacunar infarction. So as a conclusion, look at the two weighted images to examine the basal ganglia, thalamus, cerebellum, and brainstem for pathology such as old or especially old lacunar infarctions. Now, what I also check on the two weighted images is the cerebellopontine angle, because if you do that in each and every patient, every now and then you will pick up an incidental small vestibular schwannoma. If you keep doing it over and over again, you will discover a few of them in the course of your career. Have you saved a life? Well, probably not. In most cases, a wait and see approach will be adopted, but as a radiologist, it is our task to discover everything that is potentially relevant, and I always find it kind of satisfying to discover a potentially relevant incidental finding like this. I also look at Meckel's cave. You don't often see incidental pathology in Meckel's cave, but this is a case where we did. This was a patient which, oh, I don't remember the clinical symptoms to be honest, but this was a surprising finding. The cerebellopontine angle looks normal, but in Meckel's cave, which contains the gaster ganglion of the trigeminal nerve, you should normally see a T2 hyperintense fluid signal and some nerves running through it. Instead, we see solid tissue over here that is enhancing on T1 weighted images with gadolinium, and this was due to neurosarcoid. As said, you will rarely discover an incidental finding in Meckel's cave, but I look at it nevertheless. I also look at the intracranial arteries, so these should be black, both the arteries and the dural sinuses, and we know that or if you examine your cerebral arteries on every T2 weighted sequence you see, every now and then you will pick up an incidental aneurysm, in this case of the anterior communicating artery. This is another example. On the FLAIR images, we see at first sight nothing out of the ordinary. Suddenly we see some widening of the subarachnoid spaces over here anteriorly in the sylvian fissure. This looks a bit strange. Is this some kind of flow effect? Not really sure. But on T2 weighted sequences, it becomes clear that the patient has a quite large aneurysm of the left middle cerebral artery. So always check the typical locations for cerebral aneurysms on your T2 weighted images, such as the anterior communicating artery, the middle cerebral artery bifurcation, the basilar head, and the origin of the posterior inferior cerebellar artery. If you do that, you will every now and then pick up a small aneurysm, and in that case, you might have made a difference. You'll never know for sure, but you might have prevented the patient from succumbing to a subarachnoid hemorrhage. So do it. Of course, you'll only pick up aneurysms of a certain size, but it are especially aneurysms of a certain size that will undergo elective treatment. Very small millimetric aneurysms will probably not be treated with elective coiling, but will undergo a wait and see approach. Then what do I also examine? Do you see it? Do you see the abnormality? Look at the internal carotid artery. This is the cavernous segment on the left side, and on the right side, we see that the signal is not black, but hyperintense. And it's also true here in the petrosal segment of the right internal carotid artery. This was a chronic internal carotid artery occlusion we see on these TOF images, time of flight images, that the right internal carotid artery is completely missing. And this is another example. Here is an arrow pointing to a hyperintense right internal carotid artery that is completely absent on this time of flight image, in which we see that most of the intracranial arteries have multiple foci of narrowing, probably due to generalized atherosclerosis. Let's move on to the next image. And oh, this is a tricky one because I had to look very carefully myself now for where's the pathology. This is the left internal carotid artery, looks normal. We see a black dot due to flow void. And this is the right internal carotid artery. And do you see this? This looks a bit hyperintense. The wall of the right internal carotid artery is thickened and hyperintense because it's a mural hematoma, and this patient has a right-sided internal carotid artery dissection. This truly was an incidental finding in a patient who received an MRI because of headache, suspicion of migraine. Also look for flow voids in your dural sinuses. In this patient, we see that the right transverse sinus is completely hyperintense. It's also hyperintense on your FLAIR images, and this was due to a dural sinus thrombosis that was basically coincidentally detected in this patient. Then, when I'm done looking at these specific brain structures and the vessels of the brain, I look at the extra cerebral structures. I look at the orbits and I magnified a few of them. And most of the times you can see something out of the ordinary, but not necessarily pathologically. This patient probably underwent cataract surgery and has a lens implantate here. We call that pseudophakia. This one has it bilaterally. We also see that the shape of the eyeball is abnormal, and basically all these patients, this is often the cause of chronic, long-standing, severe myopia, leading to weakening of the eyeball wall. I often refer to that as staphyloma, although the term staphyloma very specifically refers to weakening of the posterior part of the wall of the eyeball. So that's probably not always correct, but in the end, this is often an incidental finding on an MRI of the brain. I just write it down in my impression, or in my description rather. So I looked up if there's another term, if it's more generalized, haven't really found it yet. So I stick with staphyloma at the moment because most people know what I mean when I do that. Here's another finding that is probably more relevant for this patient, also an incidental finding. Let's magnify the orbits and we see thickening of the wall posteriorly of the left eye. Here's an arrow to help you see it, and we see that this is contrast enhancing. This is suspect for a very small intraocular tumor. Could be a metastasis, could be a melanoma. Those are the two most frequent intraocular tumors in adult patients. Last incidental finding in a patient on an MRI of the brain is this. We see these structures, which are a bit V-shaped, coursing towards the optic nerve. This was a chronic retinal detachment, incidentally picked up. It's of course hard to imagine how you can have a retinal detachment and not see a physician. How can this be an incidental finding? Unfortunately, this patient was severely mentally, how can I say that correctly, impaired. So that's the reason why this probably was never detected or reported by the patient. Then, when I'm done with the orbits, I look at the mastoid air cells and the paranasal sinuses. This was an intensive care patient, and because they are intubated, cannot swallow anymore, we often get effusions in the middle ear and mastoid cells because the eustachian tube does not open regularly anymore to drain the mastoid air cells. This is often sterile, so don't call that an automastoiditis. We don't know if it's infected or not. And in automastoiditis, patients often have clinical symptoms. So I just call it an effusion, and based on the image, I can't say if this is infected or not, of course. Patient also has fluid level and the sphenoid sinuses. We can often see mucosal thickening and or fluid levels in the paranasal sinuses as an incidental finding. Like in this patient, clear mucosal thickening in both maxillary sinuses and a fluid level in the right maxillary sinus. I report those self-evidently, and especially in patients with headache or with infectious symptoms, these can be relevant findings. Let's not forget the soft tissues of the neck, of course. Let's magnify the nasopharynx. This is a 10-year-old boy, and we see that the adenoid tissue of the nasopharynx is very pronounced. Adenoid hypertrophy is very frequent in children, and we often see these very small cysts located in the adenoid or the nasopharyngeal adenoid tissue. This looks very similar at the first glance. We see very bulky nasopharyngeal adenoid tissue, but the difference with the previous patient is that this is a 60-year-old female patient, and that makes adenoid hypertrophy a bit less likely. Furthermore, and this is also something you should check on your T2-weighted images, the patient has a large mass lesion in the right parotid gland. What did the patient have? Well, I'm not showing you the images, but both these lesions were severely diffusion restrictive, so this was a lymphoma. the main message here is this is not about differential diagnosis. This is more about these are areas you should examine on your MRIs of the brain because they can harbor incidental pathology. This was not suspected in this patient and was basically an incidental finding. T1 weighted images. In our center, we do them in the sagittal plane. I examined those for T1 hyperintense lesions. Most pathology is T1 hypointense. So if you see something that is hyperintense, that can be suggestive for a specific diagnosis or differential diagnosis. Of course, this presentation is mainly about how to examine a normal MRI of the brain, so I'm not going to go into detail on the specific T1 hyperintense lesions. I mainly use the sagittal T1 to examine the anatomy of the midline structures, such as the corpus callosum and the pituitary and the pineal gland, and also to look at the bony structures of the clivus, but also the skull and the part of the cervical spine that is on the images. A very quick overview of T1 hyperintense lesions, just for the sake of completeness. What can cause a lesion in the brain to be hyperintense on T1 weighted images? A subacute hemorrhage, so blood. Then we see on CT images a very hypodense curvilinear lesion along the corpus callosum, hyperintense on T1. This was a lipoma, so fat is hyperintense on T1 weighted images. Then this is the same patient of whom I've shown you the T2 weighted images, a thrombus. This was a thrombosed right transverse sinus. So basically the same as the hemorrhage, blood. So thrombus is T1 hyperintense, a subacute thrombus. Certain minerals like manganese, but also calcium can be hyperintense on T1. And lastly, proteinaceous fluid. These are different cystic lesions. This is a colloid cyst. This is a Radke cleft cyst. And this was a craniopharyngioma with a very large cystic component. And these are all filled with proteinaceous fluid, causing them to be T1 hyperintense. An example of a child with calcifications in the thalamus on both sides. This was a cause of radiation. This was caused by radiation therapy over this area. And we see that these are hyperintense on T1 weighted images and corresponding with clunky calcifications on CT. This was a patient with FAR disease. We see T1 hyperintense lesions anteriorly in the basal ganglia corresponding with calcifications on the CT images. Now, what do I do? So basically, I just scroll through the sagittal T1 weighted images to see if something T1 hyperintense jumps out. Most of the times it doesn't. And then I just examine my anatomy. I look at the corpus callosum, and to be honest, sometimes, well, infrequently, you'll see an incidental callosal agenesis, but most of the times it's known, and these are mostly discovered in children anyways. So most of the times corpus callosum is normal. I look at the pituitary. Every now and then you will see an incidental adenoma of the pituitary, and I look at the pineal gland, very often containing cysts, but most of the times these are completely irrelevant. And then, not unimportant, I also look at the clivus, and the signal of the clivus on T1 weighted images should be hyperintense because the clivus contains fatty bone marrow in adult patients. And the same is true for the part of the cervical spine that we can evaluate on T1 weighted images and the skull. Normally, in adult patients, and the older they are, the more hyperintense it should be. These are patients with pathological entities. This is a patient with a very small, well, pathological as a big word. This is a patient with a very small colloid cyst. When the cyst is very small, the neurosurgeon will probably follow it up. Larger lesions will be operated upon. This is a small T1 hyperintense lesion, and pituitary gland located between the anterior pituitary and the posterior pituitary. This is a so-called Radke cleft cyst. So these are examples of T1 hyperintense incidental findings on standard imaging studies of the brain. This is also an important one. Let's magnify the clivus. We see that the normal T1 signal of the clivus is missing. This means that the fatty marrow is replaced by something else, and in this case, this was a bony metastasis. So always examine the clivus for signal changes, and especially in older patients, something like this should immediately make you worry that the patient has bony metastasis. Let's examine this patient. The clivus looks normal, but the pathology is now located in the cervical spine. Here we see a hypointense lesion in the body of the third cervical vertebra. This was also a bony metastasis. Diffusion-weighted images, I'm going to be very short because I'm mainly going through my approach of a normal MRI of the brain. And diffusion-weighted images are mainly relevant when dealing with pathology. We look for pathological diffusion restriction, and the main pathology, but not the only one, is for the detection of ischemic infarctions. This is what normal diffusion-weighted images look like. We always have to examine the diffusion-weighted images along with the ADC map. And there is, well, basically, why do I call it pathological diffusion restriction and not just diffusion restriction? Because you always have some diffusion restriction in the brain. It makes sense. If there was no diffusion restriction in the brain would be completely black, just like the ventricles are, because there is barely diffusion restriction in the ventricles. Water molecules can move freely in the ventricular system. On the ADC map, the signal of cortex and white matter looks almost exactly the same, so it's very hard to distinguish the two, and the ventricles are white due to CSF and facilitated diffusion. The main thing we do with diffusion is detect ischemic infarctions. In this patient, the patient has a lot of microvascular white matter changes in the brain. It's impossible to detect an acute ischemic infarction just on FLAIR alone in this patient, but luckily we have the diffusion weighted images and we see a lesion that is bright on diffusion, and this is going to be black on the ADC map. This is a larger acute ischemic infarction. It is bright on diffusion-weighted images and black on the ADC map, as it should be to be true diffusion restriction. If you want to know more about diffusion, there's another video on how to interpret diffusion-weighted images on this channel. The last sequence I examine are the T2 star images. We use those to look for susceptibility artifacts, and most of the times that's to look for microbleeds, although calcifications can also cause susceptibility artifacts. I'm giving you an example. We see here the FLAIR and T2 weighted images of an older patient. We see nothing out of the ordinary, some white matter changes along the ventricles maybe, but then we look at the T2 star images and we see a lot of very small black dots. These are microhemorrhages, and the distribution, which is very superficial in the cerebral hemispheres, is very specific for one specific entity, namely cerebral amyloid angiopathy, a disease in which patients have amyloid deposition in the vessel wall, causing the vessels to become very fragile and rupture, causing these microhemorrhages. And this is another patient, or this is just comparing a patient with hypertensive microbleeds, which are mostly located in the basal ganglia and thalamus and the deep brain structures, compared to a patient with cerebral amyloid angiopathy. All microbleeds are located superficially in the cerebral hemispheres, and none are located in the basal ganglia or thalamus. Let's move on to the key messages. So let's summarize. What is my approach to an MRI of the brain. I start with the FLAIR images and I do a quick pathology check. I look at the degree of cerebral atrophy. I evaluate the white matter and the ventricular width. Then I look at my T2 weighted images, and now I carefully look at the basal ganglia and thalamus, brainstem and cerebellum. I look at the cerebellopontine angle and Meckel's cave. I look at the flow voids and the intracranial arteries and dural sinuses, which should be there, they should be black. And I look for the presence of possible cerebral aneurysms. And I also examine the soft structures of the neck, the nasopharynx, parotid glands, and the paranasal sinuses, mastoids, and orbits. T1 weighted images, I do a check for spontaneous T1 hyperintense lesions, and I evaluate my midline structures such as the corpus callosum, the pituitary gland, and the pineal gland, and the bony structures of the skull, the clivus, and the cervical spine. Diffusion weighted images, or mainly for the quick detection of an acute ischemic infarction, and T2 star images for the detection of microbleeds and also possibly of calcifications. So I hope you find this useful. It was very basic and it's also very personal. There are a lot of ways to approach an MRI of the brain. This is how I read an MRI of the brain. These are the things I look for. These are the things I report. These are the things I evaluate. Maybe you do not agree or you have a different approach. And if you want to share your experience, please do, because we can only learn. If you have questions, comments, or feedback, leave a message in the comment section, or you can also send me an email, neuroradiology.online@gmail.com. Thank you very much for watching.